Well, welcome to the second hour of A&T Lectures. And my name is Gary Kaufman. I've been a career-long respiratory therapist for probably more years than anybody on this webinar. I started back in 1974 as an RT student, graduated two years later. And I've been proud to be a respiratory therapist for all that time. I grew up in Pennsylvania, served at my region, my district, state level, and was fortunate to serve in the House of Delegates, the AARC Board of Directors, and ultimately as your AARC President. So with that, I'm going to talk about ethics. And I call this a new twist on an old topic, and I'll explain why. Here are my disclosures: consultant speaker for Monahan Medical Corporation and a manager of Kauffman Consulting. That is my role here today. All those other roles are fiduciary and my volunteer roles with the AARC, my state society, and others. My disclosures: I'm privileged to be able to utilize the proceeds from my honorarium to benefit each of these organizations that my wife and I support. And what I got this phrase from someone actually at the Winston-Salem Rescue Mission: food and clothes for the body, hope for the soul. Here are the learning objectives, and you have seen these online. I won't read them, but I want to give you an appreciation for ethics. I'm not a physician. I'm not a psychologist. I'm not an ethicist. So I'm talking to you as a respiratory therapist. The slides that you'll see, the words that you'll hear, are those mostly what I've learned from others. They could be respiratory therapists, nurses, physicians, ethicists, administrators, texts, and articles. What my goal is personally is to take all of that very, very detailed information and make it basic so we can look at a particular approach and say, I'm not the physician, I'm not the captain of the ship, I'm not an ethicist. How can I practice ethically? And I'll end on that. So I Googled, like you, and I just start typing in ethics, and I came up with a whole bunch of words. I'm here to tell you, I don't know what half of those things mean. Utilitarianism, deontology, consequentialism, moral culpability, relativism, knowledge ethics, power ethics, non-maleficent. I have no idea what half of those terms are. So I sat down with a piece of paper and pencil, and I looked them up, and I found out that as a respiratory therapist, these all may impact me. I need to at least know at a surface level what these mean, so that I can practice as an ethical respiratory therapist. So I mentioned I'm not a physician, behavioral health professional, or ethicist. I'm going to talk about the tip of the iceberg. There's far more to ethics than what you'll hear from me. My little part is the tip, or maybe in some cases, the tip of the iceberg. So here's the outline. What is ethics? And I'm going to give you several definitions because there is not one and only one definition for ethics. I'm going to give you a case study, which is probably difficult for us to walk through, but it's a real situation, de-identified certainly, and then talk about these ethical constructs or approaches in the practice of ethical care. I'm going to land on what makes an ethical respiratory therapist. So I'm not going to suggest you memorize these, but in my research over the last 4 months in putting this presentation together, I read more books on ethics than I had read in my entire life. And some of these are very thought-provoking. So this is Dr. Winter, who said, the goal of ethics is save the salvageable, relieve suffering, and allow the dying a peaceful and dignified death. I don't know Dr. Winter at all, but this is his approach. If an individual can be saved, medically, surgically saved, he would do that. He would relieve suffering. And also, in that third one, it may be difficult to swallow, but if the individual says, it's my time, allow them to do that in a peaceful and dignified manner. We're all not going to be on the earth forever. So what is it that we can do as ethical practitioners? Good old Webster. Back in the day, in fact, I probably still have my paper Webster dictionary. Here's the definition according to Webster. What is ethics? A system of moral principles. I'm going to come back and I'm going to land on moral because I don't know that that is what a lot of folks would accept in an ethics definition. But this is Webster. Rules of conduct recognized with respect to a particular class of human actions or a particular group of culture. So what are the key words? Ethics is a system. It includes principles. It helps conduct by providing rules or guidelines for conduct. And it's based with respect to a particular group of culture. And I'll give you some examples about that because what we do in one culture may be seen to be abhorrent in another culture. So my takeaway from this is if I govern in a particular system of principles and rules that I have in my culture, I dare not apply my thoughts, my perspective, my cultures, my rules of conduct to another culture. Who am I to say? So that's my takeaway for this. As I did my research, this is what ethics is not. And I'll just take a minute to explain these. A set of rules. There is not one set of rules that said, this is black, this is white. This is good, this is bad. What you do or don't do. There's a whole bunch of rules, a whole bunch of guidelines. Ethics is not my opinion. Each of us has an opinion. That ventilated patient is not going to live. I may have one opinion, yours may be opposite. That's not ethics. Good versus bad. And I think a lot of times we get caught up in this when we think, what's the best? We're taking that patient off the ventilator, turning off the ventilator. Is that bad? Is it good? It's neither. And I'll show you some examples to explain this. It's not right and wrong. The right thing to do sometimes is right. You see a speed limit sign, drives 55. That's right. That's the way to do it. Can you drive 65? Yep. That would be wrong, but we don't always get caught doing things wrong. Driving a car as a respiratory therapist and others. Ethics is not the same as religion. And I was always told, never talk religion and politics outside your family or close circle of friends. I'm not going to talk about religion. But religion is not ethics. Religion may be what defines your set of rules, how you look at things, your constructs, your principles, but it's not religion. Your religion is your religion, or lack thereof. It's not the patients, it's not the family, it's not others. And it's certainly not patriotism. And I was surprised that this even came up in my research. We'll do this because you're being a good patriot. That has nothing to do with it. Okay, so what is ethics? Here's an interesting quote. And the last part's maybe a little difficult. This is Daniel Callahan, director of Hastings Center, think tank. Excuse me once again. Our great tradition of medicine has always had a bias towards saving life. Bias means you think about saving life first. It made a great deal of sense until we had the kind of medicine that keeps people alive longer than is good for them, treating them beyond anything good for their benefit. So you think about that. What's the golden rule? As I was taught, is do unto others as you would have them do unto you. Does that mean that I can force or utilize my point of view and tell others this is the point of view that you can have? Absolutely not. That's not what we should be doing as ethical individuals. The other thing we know that I believe Daniel Callahan says is that we need to be talking to the patient before they're a patient. That's why we have living wills and durable power of attorneys and all that stuff that lawyers understand, and quite frankly, I don't. But at the bedside, I know we need to let the patient, if possible, or families, caregivers, those that have those legal rights. It's not about always doing the same thing in the same way, because that's what we did it. So here's another set of words. These are mine. And look them up. I just sat down and I started writing words down. It said, for me, ethics is something like this. It's a system, has values, beliefs, principles, and guidelines. And that combination, that system, governs conduct. It tells me what to do. In the speeding example, I was taught by my dad and my driver ed teacher back in the day, if it says 55, go 55. Sometimes I can't drive 55. Okay, that's a song, that's a quiz. But whether you're Sammy Hagar or Gary Kaufman, you have to decide whether your conduct is governed by values, beliefs, and principles. Or, no one's looking, I'm going to drive 75 because I like to drive 75. So for me, this is just me. A system of values, beliefs, principles, and guidelines that govern conduct. That's how I think about the situation, how I would act. One of the terms that came up is relativism. And this is an action that can only be judged as acceptable or unacceptable relative to the group in which the action takes place. And I'll give you a cultural example, but first, here's a simple one. It's in Phoenix, Arizona, and it was 115 degrees. This is AARC meeting a number of years ago. When we came inside, it was like 60 degrees. I mean, it was just night and day. And somebody who was a local said it was like 90 degrees at 8 o'clock. Wow, it's 90 degrees. Man, I'm glad the weather's cooler. The other person said, geez, it's 90 degrees. It is hot. That's relativism. So think about that very simple example. It's hot because I'm a Northern Yankee. And when it gets to be 90 or even 100, it's hot. But if you're living in that environment where it can be 115, 100, even 120 degrees during the day, and it's 90 degrees, at dinner time, that's pretty cool. So relativism says we need to think about it in the context of that group. Now, this is historically, and I don't think that this is the way this culture behaves today, but historically, for the culture to survive, elderly, sick Eskimos who could no longer contribute walked away and didn't come back when it was their time. Just doesn't feel good to me. That was their culture. Again, I'm not an expert in this. I don't think in any way, shape, or form this is today. But my research said that's relativism. Should I say, don't do that? That's not right. Grandpa needs to stay with us. I don't have the right. It's their culture, their principles, their values, historically. Now, baseball fans, certainly a Phillies addict since the day I could watch TV or see the Phillies play, and played baseball, a number of sports, mostly mediocre. But this guy on the left, he was the guy. Mickey Mantle and Roger Maris, his teammate for the Yankees, hit 60 and 61 home runs in 1 year. That's since been eclipsed, even most recently. But Mickey Mantle was a self-professed alcoholic. Who's the guy on the right? Larry Hagman. Used to play a TV show called Dallas. Self-professed alcoholics. Each of them got a liver transplant. So the question I would ask rhetorically, is that fair? What about the individual on your transplant list at your hospital or the hospital down the road who's on a transplant list waiting for liver, kidneys, whatever the organ might be? Is it fair that someone who has the financial resources, money to be blunt, can kind of jump the line and get a liver transplant? Is it right? And I'll caution us, it may not feel right, but that's what happens. I don't know if you've heard the word medical tourism or not. Probably, 12, 15 years ago, I heard this term, and it allows those individuals, and obviously to have the resources to do so, to travel to another country to get surgical procedure. I remember reading one about open heart surgery. You can make a call, get in a plane, have an open heart surgery next week in this other country, in good quality, I might add, or you might have to wait a year in the US. Is that right? That someone who has the money gets kind of front of the line. The other thing to think about is, could that money be spent in another way to help more people? So here's an example. May seem silly, but I like simple examples. What is equality? What's pragmatism? 30 people need a liver. They're on the list. You have one, and you say, I can divide it into 30 parts, or take part of my liver, give them each 30 parts. They're going to die. That's a silly clinical example. On the other hand, if there's a trauma victim who's declared dead, do you take that liver and give it to the sickest person on that list when the physician said the sickest person on the list is most likely going to die and will not get the value of that liver? That's rhetorical, but think about what is the culture, what are the rules, the guidelines, the principles that might help you do that. So here's a real live example. He identified person very wealthy, donates $5 million to a liver foundation. Shortly thereafter, gets a new liver, gets a reused liver. The foundation, with that $5 million, can hire people, can get the equipment, and as a result of that one person of means giving that $5 million, 60 people get transplants. What's the negative way to look at this? How'd the rich person do this? They jumped the line. And we all know how that $5 million allowed them, or I should say, we assume from our perspective that the $5 million was the easy button that got them in a line, but maybe not. Positive, 60 people were helped. So what if that person said, I'm going to go to another country, get a liver, come back, I get a new liver, or a used liver, but a working liver. 60 people wouldn't have been helped. So it might kind of get under your skin that somebody who has more money than all of us combined will ever see gets a liver because they have money. But how would you look at that? Or would you look at it differently if 60 people were helped? So I came up with this list to use this as part of a case study. And for me, again, a respiratory therapist, ethics is how to make decisions. Why do we need to decide? Do we even need to decide? Who decides? Who will be affected? Who should be informed before a decision is made? So I'm going to use this outline, again, just from my research and listening to others and reading text and articles, use this approach to go through a situation with clinical ethics. So what is the definition of clinical ethics? This is one that I found. It makes sense to me. Clinical ethics is a practical discipline that deals with identifying, analyzing, and resolving moral and ethical problems as they arise in the real world setting of caring for folks. Discipline, identifying, analyzing, using moral and ethical problems, or to resolve moral and ethical problems when we care for individuals. And I don't know that this is the best definition, but as I look at it, it just makes sense. It helps me understand the categories and the aspects of a process of an individual. So let's talk about that. In one approach, ethics, they divided ethical decision-making based upon these three approaches: knowledge ethics, consequence-based ethics, and deontology. I didn't even know what deontology was till I read the article. So what I'm going to use is a real live example illustrating how each of these approaches may be useful and really thought-provoking, not telling you which one to use, or this is the right answer, the wrong answer, this is good or this is bad, but rather just makes us think more. So let's look at each of these individual approaches. So knowledge ethics. Knowledge ethics is based upon the medical knowledge of the hope or hopelessness of the situation. This is a physician, this is a respiratory therapist or nurse. This is that informed physician who knows best what is likely to be the outcome. So here's a case study, de-identified. And I may pause once or twice. I've done this similar lecture a number of times, and the case study may cause me to pause. So I apologize in advance. An infant is born without a brain. Each day, the child is kept in life support costs about $25,000. At this point, the costs are over $150,000. That's the cost, not the charges. There's no insurance. There's an unwed mother who's a drug addict, HIV positive. The mother, and I get it, wants the baby saved at all costs. Tragic, tragic situation. I bet you've been there. Not certainly this exact case study, but you've been there. So how would knowledge ethics approach work? So here are the questions. What are the issues? And these are going to be the same for each of the three approaches. What is the quality of life for the baby and also the mom? What's the cost? And according to mother's wishes, does the mother's marital status, single, drug addiction, she's a current drug user, and positive HIV status play a role? Pretty tough stuff to talk about. So quality of life, cost, and then the mom's wishes. Using the knowledge ethics approach, let's go through each of these categories. The quality of life, the physician's going to determine that, and that's going to factor in the decision. The physician knows, in this particular case, the child did not have a functioning brain. Physician knows there will be no life. The cost will play into this because those dollars, if physician chooses to take the child off life support, those dollars in the physician's mind could be better served to help someone who will survive. The mother's wishes in this particular approach are not relevant, nor is her particular status. They're not relevant because the decision is made by the physician based upon knowing what the quality of life is. In this particular case, there would be no life as we think about it. Difficult. Second approach is consequence-based ethics. This one I got this one figured out. I didn't know the first one, don't know the last one, but what's the consequences of our action? So let's look at defining consequentialism. It is provide the greatest value, do the least disservice, or some might say harm, and respect autonomy, the person's right to choose for themselves. So it's not what I thought consequentialism would be. Greatest value, least disservice or harm, and respecting the autonomy, the person's right to choose for themselves. Same individual, baby, costs you can see. So let's look at how this would be addressed using consequentialism as the approach. So what are the issues? Same as in the first, quality of life, cost, mother's wishes. So how would we look at this through the lens of consequentialism? Quality of life, baby is not viable, therefore end life support. That's it. The consequences of this situation is the baby is not a viable human being. Difficult to say, far more difficult if you're the mom and maybe perhaps other family members, and life support. The cost is, again, difficult to read this. Money could be better used elsewhere. The baby is on a day, a week, a month, a year, maybe with a heartbeat, but is not a viable human being. In the eyes as determined by the physician, consequentialism would say those resources could be better used. The mother will be informed and involved, but her other situation doesn't play a role. We may feel bad about that. Certainly, I think we should. Certainly, I would suspect the physician would order some resources for her to help her. But that doesn't play a role because it's not part of the consequences of keeping the child alive or removing life support. And the third one is deontology. This is a phrase I heard: duty-based ethics. Always do what's right. Actions are, in and of themselves, right or wrong, regardless of the consequences. I'm going to repeat that. In and of themselves, the actions, right or wrong, regardless of consequences. The ends never justify the means. You can break or bend the rules if you're trying to do the right thing. I probably shouldn't even use the word good here, but trying to do the right thing. And paternalism plays a greater role than autonomy. Same situation. We're going to use the same approach. What are the issues? What's the right thing to do? Now, this is different for deontology. We had quality of life, cost, and mother's wishes. In this particular case, what's the right thing to do? The actions in and of themselves, right or wrong. So what's the right thing to do? What's the right thing to do in this particular approach? Do not kill. Kill, harsh word, meaning don't take life support away. So life support continues. Quality of life, not my call. Cost, not in the equation. Mother's wishes, whatever she would like, the mother may change her mind and say, I want the device taken off my child. Painful to say in this particular case, but that doesn't get the priority. It's outweighed by the right thing to do is never kill in this particular approach. Again, I'm not suggesting that any of these are right or wrong, better, worser, but it's helped me kind of sit back and say, I understand better the discussion, the process. And I don't know if you've ever been in one of the meetings where they're discussing removal or sustenance of life support, but not a dry eye around the table. This is really, really heady stuff because we're dealing with people, not a device, not a procedure, not a nebulizer, not a cannula, with people, life and death as we define it here. Now, let's just take a pause. I'll get a sip of water. You might be saying, I would be saying this, or thinking this, if I'm in front of Robert in your chair. Oh, well and good. I'm not the ethicist. I'm not on the panel. I'm not on the team. I'm not a physician. I don't decide when to sustain or remove life support. I'm the person who turns the ventilator off. That's my role. I do as I'm directed by higher knowledge and power, higher authority to do that. What can I do? Do I need to remember consequence-based, knowledge-based deontology? I don't think you need to remember the titles of those, but I think, at least for me, it helps me formulate why the decision makers, and I'm not one of those, I'm the therapist waiting at the bedside with the ventilator, how their thought process is. What is the foundation? What's the methodology? What's the approach that they use in coming to what is always a painful decision? To maintain, sustain life in this particular case, or many that you've seen in your clinical practice, or withdraw life-saving. And we're going to go back to those of you who heard my lecture earlier. When we look at life-saving, and I used the example of a ventilator, individual comes to the ER, they're being bagged by the EMT paramedic, and we put them on a ventilator because that's what we do. That's our policy, that's our procedure, that is our standard of care. Seems cut and dried, black and white. If you're doing a study to see, does that mechanical ventilation really work? When we know it does, that next individual comes in. You certainly would never say, nope, you're number 2, The odd number of patients get a ventilator, the even numbers don't get a ventilator. We wouldn't do that. That simply is unethical. And I think it's a very simple example, and some may find it to be too simple, but to me, that helps reinforce when we know that something is life-saving at that moment, talking about a code blue in ED or trauma patient that came in, at that moment, the physician says this individual is salvageable. Yeah, maybe they have a collapsed lung and a broken femur, but they're salvageable. We put them on a ventilator. The next individual, similar to the sad situation here, the physician said, there is no evidence of brain activity. Therefore, we're going to go down this path. That, to me, keeping it simple, helps me understand the process that decisions are made and not be comfortable with the outcome. I don't think anyone ever is removing life support, but understanding that this is the rationale behind it. To have a small infant like or a baby like this, or a trauma victim, or someone has severed, C, 1 through 5, having the clinical knowledge and aligning that with an understanding of clinical ethics, I think, I've heard from others, makes it easier to get through the day. It's not about us. It's about the folks we care for, the patient, the family, the spouse, extended family, community. But I don't ever want us to remove us from that equation, because I know that we go back to the room and cry. I know we walk down the hallway to find a dark spot just to stand for a minute. It's not that simple. It's not a formulation. These are guidelines, and I think it helps us. I want to talk about what we can do on our own accord to be ethical respiratory therapists. And I just have some images here downloaded from the internet of being ethical is at the bedside in med-surg, the ICU, transitional care unit, the pulmonary function laboratory, the ECMO team, that home respiratory therapist, that RT navigator, the program faculty, the administrative director. What are things that we can do to demonstrate that we're an ethical respiratory therapist? Anyone who knows me knows I like lists. I like lists because it helps me organize things. It helps me understand and differentiate. And it seems to me, this is just my opinion, we talk about leadership and management. In fact, tomorrow, if you're listening to the program, we can talk about the difference between leaders and managers. And there's two lists, but there's a lot of crossover. So in this particular case, I think of how we can be ethical is to be patient-focused rather than self-focused. So in my opinion, my experience and learning from others, what does self-focused mean? I'm self-focused. Education, I got to do it. I need 30 CEUs in 2 years to keep my license. That's true. I'm sure everyone on this webinar is saying, one of the reasons I'm listening to Alan, Terry, and Gary is I need so many CEUs. I get it. There's nothing wrong with that. But there's something more than that. Self-focused, do what's ordered. Doc orders Q4, they're not really indicated. I just do it because it's ordered. Achieves minimum competency. I am CRTT. I could sit for the registry exam. I choose not to because I don't want to put in the effort. That's minimum competency. And if you're eligible for that next level, in our case, CRT or RRT, currently, to be ethical, why wouldn't we do those things that make us better for the patient? Not us, for the patient. And I've heard in some of the, I see more of this probably on the internet. Hey, it's just a job. I'm just a respiratory therapist. That just drives me nuts. It's not just a job. We're caring for people. I'm not just a respiratory therapist. I'm a proud respiratory therapist. And I know you are too. So the words matter. Someone said, hey, you got the floors today. No, I'm the med-surg therapist. I'm going to help individuals leave the hospital. I'm going to help family members by educating them so maybe they don't come back to the hospital and they can care for their loved one by helping them taking their breathing treatments at home. So what's patient focus means? Continually improve skills and competency. You're here. Hopefully, one of your objectives is to improve your knowledge, not for knowledge itself, but to help improve patient care. Assure therapy is indicated. Use patient-focused respiratory care protocols based upon evidence, the best evidence that we have. The physician writes a particular procedure and it's not clinically indicated. Do you do it just because the doc wrote it? Or do you take a little bit of time to educate that physician? Maybe you have to start the therapy in order to have a couple of minutes time. I get it. But devoting that time to talk to the physician is patient focused. Achieves advanced competency, whether that's your registry or baccalaureate status, or your ACCS, or your NALS and PALS. We're doing that not for the letters after our name, but to help people in a way we couldn't before. And the last thing, I'll talk about this in the last slide, is we need to advocate for individuals, patients in the hospital, we call them, but individuals, and our profession. So what about patient-focused respiratory care protocols? What do? Improve safety and quality, allocate finite resources, eliminate waste, improve satisfaction, and ultimately define, document, and communicate the value of our services and respiratory therapist delivery. I probably have 100 presentations in my files. This slide comes up 80% of the time. The science of respiratory care, practicing according to that, is ethical. I consider it mandatory. I don't think you'd think for a minute, I'm going to do this procedure. It's not safe, it's not the right one, but I'm going to do it because I just like doing it. Draw blood gas when you don't need to, or a pulse ox would work. Give a breathing treatment when it's not indicated. We wouldn't do this. That's very, very basic application of how we function as ethical respiratory therapists. So what about advocacy? We hear the term, I'm an advocate for my patient. Well, we need to advocate for the individuals for whom we provide care. Patients, families, communities. One way that we can do that is right in your backyard. You can advocate for people in your community to get access to respiratory therapists, to get access to the right amount of oxygen delivery device. You can also, as your budget and time permits, join your fellow RTs at your state capitol each year for Respiratory Care Day at the Capitol, called where I came from, Pennsylvania. Every year, we had a day at the Capitol, and we educated folks that came by. A lot, mostly certainly senators and representatives of our state, but also their assistants. I'm here to tell you it makes a difference. You could do screening spirometry or peak flows or whatever you might do. One of my friends says, I always take pig lungs and a bird Mark 7 to the Capitol to show people what we do. Not that we inflate pig lungs, but this is how lungs work. This is our job. Secretions out, avoiding airway collapse. And you might actually find a youngster who would look at that and say, that's pretty cool. I'd like to do that. So think about, it starts with advocating for the people that you serve, patients, families, and their communities. Professionals never stop learning. If what I knew today was what I was taught when I was a student, I bet most of it is not right. I was taught aerosolized acetylcysteine, not validated. I was taught to do blow bottles, the prehistoric version of incentive spirometry, not validated. I was taught that everybody comes in with a wheeze or rouse, gets an IV treatment. And that's the way it was. We didn't have IMV, SIMV, we didn't have NIV, CPAP, bilevel. We had none of those things. All of that have been new clinical services in my career. And the way that we can be advocates for our patients, the way that we can be ethical respiratory therapists, is to never stop learning. Whether you read Respiratory Care Journal, and I sure as heck hope that you do, and other journals, ACCP, ATS, there's other medical journals. And there's some good information on the internet. There's some bad stuff out there as well, misleading. But understanding the science of respiratory care is one of the foundational elements, in my opinion, my experience, being an ethical respiratory therapist. I need to keep up my education in order to practice ethically. There are several areas of clinical care where I'm no longer competent, and I would have no qualms about saying, I can't do PFTs, screening bedside spirometry, but I'm not competent to do complete spirometry. I'm not competent to work in the ECMO team. Not to say we need to learn everything to work in all the areas, but we need, for the areas that we work, to have the highest level of knowledge and skills and competency. And that's ethical. That's doing the best that you can for the individuals you serve. Now, I just copied these from the AARC website, and it was interesting when I copied the picture on the right. I looked at small print, established 1981. I had forgotten how many years ago that the AARC, in fact, it was the AART when we were the American Association for Respiratory Therapy. Later, we became the American Association of Respiratory Care. That's how long your profession, the AARC, back at AART, AAIT, has been advocating for individuals. Why? Not so we can get a photo op with the senator. Yeah, we're going to get that. We're going to publicize that. But more importantly, it's the right thing to do. The Political Action Committee, we call PACT team, that is every state society, Jersey, Pennsylvania, all 50 states have a PACT committee within the state that serves the AARC. Excuse me. Oh, and PACT Day. But we can't just have one day a year. That's not enough to be ethical respiratory therapists. So the question is, we need to advocate for ourselves as well, right? I mean, who's got our back if not us? Make sure your patients know you're an RT. What I did for a lot of years is just go in the room and say, I'm here to give you breathing treatment. That's what I was taught. And one day I had a wake-up call that, hey, it's not about me. They don't even know who I am. And maybe with color-coded scrubs and all that, they can figure out who we are, but make sure your patients know you're a respiratory therapist. When you knock on the door and ask permission to enter, say something like, I am Jim Smith, your respiratory therapist. May I enter? When you enter, walk in and you're foaming up, let the patient see you're concerned for their health by using hand hygiene. I am Jim Smith, your respiratory therapist. I talked to Sue last night and she said, boy, you slept through the night. You didn't need a breathing treatment. I'm going to assess you now and I'll let your physician know how much better you are doing. Did that take any time? Yeah, the answer is 30 seconds, but I was doing something while I did that. So individuals that say, I don't have the time to introduce myself, explain the goals of therapy, ask them if I can help you, tell them what's coming next, are wrong. And please quote me on that. You're doing it. We all do it in the context of why we're doing something else. Act like a healthcare professional. RT's going wild on Facebook is probably something that's not going to help our profession. Certainly not you. Act like it, dress like it, talk like it. The stump speech, you see the elevator doors closing. You quick sprint up there and you jump in and there's an individual there. And she looks at you, look at her, and you see, oh, she is the chief nurse officer, CNO, or chief nurse executive. Could you just stare and watch the elevator lights come on? Yep. Or could you say, hey, my name is Sue Smith. I want to thank you for allowing respiratory therapists to join the rapid response team. I know you're aware, but I just found out that our nurse therapist rapid response team averted over 50% of the cases that would have gone to ICU. Thank you very much. She's going to get off that elevator, and I don't mean to laugh at myself, and thinking, hey, these respiratory therapists actually get it. I never actually talked to one who was that excited, that engaged, and was aware of the value that we bring. Volunteer to work at public health events. It's your time, and hardly anyone has the time on the clock to do this. But if you could do screenings at the mall or your state capitol, it may be the only way that a potential respiratory therapy student gets to hear about respiratory therapy. Last couple of years, we're the one to run the events. The pandemic has given us some greater attention, but not, in my opinion, communicated the value. The fact that we quote, run the events and we're indispensable, that's good, but I don't know, again, my opinion, that clearly communicates the value. We got to do that one at a time. I know one of the state societies every year has a respiratory therapy booth at their farm show. And you're thinking, what's going to happen at the farm show? I love farm shows personally. Got great food. You get to see horses and cows and pigs or whatever. What's an RT doing on a farm show? It's that mother or father who comes up and says, what's a respiratory therapist? And you educate them. And your child in maybe elementary school or junior high may get the opportunity to become a respiratory therapist. So increased exposure that costs time, maybe even a little money, maybe even out of your pocket. Health fairs, health screen events, volunteer to work for your city Department of Health if they have annual screen events. And if they're not doing pulmonary function screening, say, hey, add it to the list. Last, and I know this sounds different, may sound different to you if you're not an AARC member. We need every therapist to be a member of the AARC, period. We have maybe half of the therapists in the United States are members. I don't know in your particular state. That's not enough. We need all of us to be, because that's what an ethical therapist is. The National Respiratory Patient Advocacy Award is the only nationally recognized advocacy program dedicated to honoring outstanding registered respiratory therapists nominated by leadership. That's it. It's the only award. It's given at a special meeting the day before the annual AARC Congress. It hasn't the last 2 years because Congress has been virtual. It's the only award that's given to registered respiratory therapists. There is in nursing world, it's the Nightingale Award. This is our version. And it was put together by an individual. She lost her husband to pulmonary disease. And she single-handedly started the initiative, and the AARC now is engaged with that. Now, what are some resources you can have if you go to the AARC? A role model statement. Print it, look at it. Am I acting ethically by adhering to these standards? The AARC has a statement of ethics and professional conduct, and the AARC about 5-6 years ago created a position statement on cultural diversity to let the world know we're ethical respiratory therapists because we practice according to guidelines. We have standards of ethical and professional conduct, and we believe strongly in cultural diversity as a means to become the best ethical therapists as we can be. And with that, I want to leave a little bit of time for some questions from the group. Did this help you better understand the different principles of ethics? What is clinical ethics? Didn't talk about durable power of attorney and all those words that I don't understand, but did you get a sense? Do you have a better understanding of what the different approaches to ethical decision-making are? Where there's principles and guidelines and models and rubrics that help make decisions. No right or wrong, no good or bad, but help us make ethical decisions. And as therapists, not that we're making that decision to discontinue life support, but that we understand the rubric, the formula, the algorithm that they used to make that decision. And lastly, we're not the physician. We're not the captain of the ship. We're not making a decision, turn off the ventilator. But what can you do on your own, in your department, in your state capital, at the annual farm show to demonstrate the reason the world needs respiratory therapists. With that, thank you for being a respiratory therapist. Next week, please enjoy Respiratory Care Week 2022 for those people viewing this on demand. Hope you had a great Respiratory Care Week 2022. And with that, I will turn my video back on and answer any questions, or try to answer any questions that may have come up during the presentation.